Hey everyone, and welcome to the second part of the Chapter 13 lecture that's all about the female reproductive system. The first half we really talked about the gynecology side of things, and then the second part is really going to be more about obstetrics, the practice of pregnancy and childbirth. So my term of the day here is abdominal pregnancy. It's a type of ectopic pregnancy. So ectopic means outside the normal place. So the normal place for pregnancy to occur is in the uterus, and there's various types of ectopic pregnancies. The most common type is one that develops in the uterine tube, in the fallopian tube, but these are some other types that are pictured. A very rare type, but that can actually grow to term. So most ectopic pregnancies are terminal. So if the fertilized egg implants in the fallopian tube or in the muscle of the uterus or in the ovary, pictured here, those would not support the growth of the fetus. It might grow a little bit but ultimately would cause damage to the organ, resulting in the need for medical removal. However, if the fertilized egg escapes the uterus and enters the abdominal cavity and implants on one of the abdominal organs, the placenta can actually grow and the baby can actually grow. And this is very rare, but it does occur sometimes, and sometimes it's missed by the diagnosticians. They don't realize that the baby's not actually in the uterus sometimes until labor. But there was actually a Grey's Anatomy the other day where somebody had an abdominal pregnancy. And it's not dangerous to the baby. The baby can grow just fine and actually get nourished fine. It can be very dangerous to the mother because the placenta, as we'll see, really embeds itself in the tissue that it implants in, which is normally the uterus. And then it rips away at the end of labor and leads to a lot of hemorrhaging, sometimes fatal hemorrhaging, and is particularly dangerous when it's attached to an organ that it's not supposed to be ripping away from. So in the Grey's Anatomy episode, it was attached to a liver. They had to do surgery and they had to make sure they saved her liver, but it's very dangerous for the mom. So this is a video link that doesn't work anymore, but it was to a case of a real woman who had an abdominal pregnancy and had to have an emergency cesarean and almost died from blood loss. She had to have like 4 blood transfusions or something, but she survived and her baby was fine. And it's just a super rare, weird thing, and doctors still don't understand how it happens. Like how that fertilized egg escapes the uterus is really unclear, but it's a pretty interesting phenomenon when it does happen. All right, so this topic of this part of the chapter is all about pregnancy and childbirth. So pregnancy starts at conception. That is when sperm meets egg. And as my daughter says, the daddy seeds race to the egg and then have a digging contest. And whoever wins the digging contest gets to grow the baby. That was her explanation, like almost verbatim when she was 6. You can tell that she's the daughter of a science teacher. All right, so 1 sperm, 1 egg get together, make a fertilized egg, which is called the zygote. In biology, we call it the zygote. So the sperm has 23 chromosomes from dad. The egg has 23 chromosomes from mom, and they fuse so that the fertilized egg has a total of 46 chromosomes. And then the cells just start dividing and dividing and dividing and dividing, and they all have 46 chromosomes from there on out. So in this early stage, they divide, they're doubling, and then the cells start to form this hollow sphere with a mass of cells at the center. And this inner mass of cells, FYI, is what people talk when they're talking about embryonic stem cells. They're talking about doing research on these stem cells. So embryonic stem cells are formed in a dish by taking a sperm and an egg and fusing them and then letting the cells divide for a couple of days. It's not even like an embryo yet. It's at this blastocyst stage where it's just a ball of cells with a little circle of cells in the middle. So these cells, the reason people do research on embryonic stem cells is because these cells are what are called pluripotent. It means they can become any type of cell in the body. So they're still like blank slates. So you could turn them into heart cells and use them to cure heart disease, or you could turn them, potentially, there's research looking at injecting them into injured spinal cord so they can develop into spinal cells and repair spinal injuries. So that is the beauty and magic and specialness of those cells right there. So those cells are what do develop. If the embryo continues to development, or the blastocyst continues in development, will ultimately become the embryo and the amniotic sac. And then these blue cells on the periphery, those will be eventually become the placenta. And the placenta is sort of like the feeding mechanism for the embryo. So at this early stage, already at this blastocyst stage though, these cells start to produce a hormone called human chorionic gonadotropin, or HCG, which is the hormone you test for when you do a pregnancy test, whether it's a pee test or a blood test. You are looking for the presence of HCG, and it starts really very early on. So that's why you can tell before the woman is showing or necessarily even experiencing any symptoms, you can detect HCG. So the medical term for pregnancy is gestation. The period of time from fertilization until birth is the gestational period. And it's an average of about 40 weeks, plus or minus 2 weeks. So 38 to 42 weeks is sort of considered within a normal range, healthy range to have the baby. Longer than 42 weeks is not medically supported. And before 38 weeks is technically considered preterm. So it's a pretty long period. It's about, 10 months total. And we divide it up into 3 trimesters. Some other terminology to know surrounding this period of gestation is the fertilized egg. The scientific term for that is the zygote. Then between the zygote and about 13 weeks, like the end of the first trimester, or no, it's more like 9 weeks, I think. It's about halfway through the first trimester. We refer to it as the embryo. So the embryo is still very poorly formed. It's not quite formed yet. Doesn't quite have all the foundations of different organ systems. And then around 9 weeks, we start calling it the fetus. So these represent different stages of development. An embryo is a very early stage of development, and then the fetus is once it's starting to actually take form. The gestational period for the baby is referred to as the prenatal period. So you do a lot of prenatal appointments when you are pregnant for the OBGYN to check the baby's vital signs and to make sure that the fetus is developing correctly. They're also technically antepartum visits, because they're also checking the mom to make sure that she is healthy and not suffering any negative symptoms of pregnancy or diseases or problems. So the 3 trimesters are divided into roughly 12 or 13 week periods. So in the first trimester, there's not a lot visually like size-wise happening. Mom sometimes will maybe gain a couple of pounds, but sometimes not. A lot of times women have morning sickness during the first trimester, which makes them lose their appetite. So sometimes they even lose weight in the first trimester. Although by the end of the first trimester, you do have a tiny little fetus that is like fully formed, but just really, really small and immature. It's very, very small and immature, so you don't see a lot of growth. But all of the foundations for the fetus are laid in the first trimester, which makes the first trimester really the most fragile trimester, because if anything goes wrong in those early stages of development and those early cell divisions, if there's an error or a mutation, then that just snowballs as the fetus grows. And so the first trimester is also the most likely time to miscarry. Something like 80% of miscarriages occur in the first trimester. That's why a lot of a sort of cultural norm in Western culture is often to wait until the end of the first trimester before telling people that you're pregnant, because that first trimester is definitely more risky. The second trimester, a lot of growth occurs. The mom's belly starts to grow, the uterus expands, and the fetus elongates, and the organs start to mature more, the bones start to harden. And in the third trimester, again, the organs continue to fully mature, but also the fetus starts to gain a lot of weight and put on a lot of weight, some fat, and store iron, and get ready basically to be born, get into position to exit the uterus. So labor, it occurs, ideally between 38 and 42 weeks. During the third trimester, the fetus is getting into position. That's called engagement, preferably in the head down position. So that's the safest way for babies to be born is head first. So we call that cephalic presentation. And really you want the vertex, the tip of the head. Babies' heads are a little bit egg-shaped. So you want the tip of the head to be facing the cervix. If their head is tipped back like this and they're trying to come through face first, it doesn't work so well. You don't fit so well. So engagement, head tucked and head down is the ideal. We'll talk about if a baby is breech, if they're butt first or foot first, it's just more dangerous for delivery. The mom's body, the uterus, will also start preparing for labor by doing these sort of practice contractions. So it's not uncommon in the third trimester to feel contractions that are known as Braxton Hicks contractions. Sometimes they're called false labor. Most women who experience them, they're painless contractions. They just feel like little, painless muscle spasms kind of. But in some women, they can actually be very painful. But it's basically the uterus preparing, contracting, and exercising itself to prepare for labor contractions. So labor itself is divided into 3 stages. Not everyone knows this. I didn't know it until I had a baby, because I really only knew stuff about labor from, Hollywood, from movies, which is very truncated. Now I like to watch, actually just finished watching all 9 seasons of Call the Midwife. You learn a lot more about pregnancy and labor from that show. I recommend it if you're interested in this topic. All right, so the 3 stages of labor. The first stage of labor is the contractions, and your cervix is dilating and effacing. So it's widening, starting to widen in order to allow the baby to come out. That stage can be very long. It's the longest stage of labor. It can be a couple of hours to a couple of days. So a couple of hours would actually be a very short first stage of labor. Several hours to several days is actually more normal. And so that's when you start having contractions that are coming regularly, every 10 minutes, then every 8 minutes, then every 6 minutes, and so on and so forth. So they get closer and closer together. Some of the time, maybe half the time, I think actually it's like 30% of the time, the rupture of membranes happens in the first stage. So the rupture of membranes is what we colloquially refer to as your water breaking. The amniotic sac ruptures and all the amniotic fluid spills out. In Hollywood movies, I feel like that's always how labor begins. It's always like, oh my gosh, my water broke, because it's such a dramatic way to start labor. But in reality, most labors do not start with the water breaking. They start with contractions coming. In fact, in a lot of labors, the water doesn't break until the baby is actually born, until you're actually in that second stage of labor and pushing. So the second stage of labor is really that stage where you're pushing the baby out. So a lot of labor is just breathing through contractions as the baby is getting into position. When the baby's head is visible at the vaginal introitus, that's called crowning. And that's when the pushing really begins. So, and the baby gets pushed out. So the second stage of labor is usually relatively shorter. It can still be a couple of hours. There are still people who go through, 2 or 3 hours of pushing to get the baby out. And then so the baby's delivered, and the umbilical cord is clamped and cut. That's the second stage of labor. And then there's the third stage of labor, which I don't even think I realized until I was pregnant. They never show you this part in the movies. They do all the time and call the midwife. But the third stage of labor is the placenta needs to come out as well. So the other end of the umbilical cord is attached to the placenta, and it also needs to leave your body. And so that's the third stage. And it's actually a very important stage of labor, because if the placenta doesn't tear away properly, or a little bit of it is left behind, it actually can really threaten the life of the mother due to hemorrhaging or infection that can occur. It's actually a very important stage, even though it's often overlooked in the romanticism of labor and delivery. So the period after birth is referred to as the postnatal period. So you might go for postnatal or postpartum checks. So the postpartum really is referring to mom's state, and postnatal is the baby's state after birth. And then this little thing that just came up under my face is that full term is considered 38 to 42 weeks. Anything before that is really considered preterm or premature. And we have really come a long way in neonatal care in improving the success of births that are preterm and premature, but they definitely come with more complications and usually involve a NICU stay for a little while until they put on some weight and mature enough to go home. So this is just a visual of that, of labor. So before or during the first stage of labor, when the first stage of labor starts, the cervix is still closed, it's still fully formed, but during that first stage of labor, over the course of several hours or several days, that cervix will slowly dilate and become effaced, so that now there's room for the baby's head to come through. So that part can take quite a while. But once it's done, once the woman is fully dilated, then it's time to start pushing. When the head is poking out of the vaginal introitus, that's crowning. The baby's head is crowning. And then the baby is born, comes out, and the third stage of labor here is the placenta being delivered, usually within about 30 minutes. Somewhere in that 30-minute range is normal. So the newborn is called the neonate, literally means newborn, and it's covered in a slimy, cheesy kind of a substance, almost like its own body butter. And that is because if you think about it, the fetus is floating around in amniotic fluid. It's basically like living for 10 months in a hot tub. Think about when you spend time in a hot tub and your skin gets all wrinkled and raisiny. And so the vernix caseosa, which is what that body butter is called, is there to protect the skin while it's floating around in that amniotic fluid. So it comes out looking kind of cottage cheesy, and we usually wipe that off. Another thing that's common in neonates, especially if they're born vaginally, is for the head to exhibit molding. So their head can be like cone head shaped, a little bit malformed, because again, they have the fontanelle, that soft connecting thing for their skull bones. All right, so the cranial bones are not fused together yet, so they can actually be compressed, and they do get compressed through the vaginal canal. And that the head reshapes over the first few days, but when it first comes out, sometimes they have these kind of pointy heads from being squeezed through the vaginal canal. Sometimes you hear people talk about how C-section babies are so pretty because their heads are nice and round and they don't have that molding because they don't have to do the squeeze. The fontanelle is that soft area that I was just referring to. It's not uncommon for babies to experience acrocyanosis, which is bluing of the extremities, the hands and feet and nose, at least in the first few minutes of life until their oxygen is really getting well distributed to the extremities. The first stool that's produced by the baby, the newborn, is called meconium, and it's like a thick, sticky, black, dark green stuff. It's like chewed up Tootsie Roll. It was like a really gross picture probably, but it's a different consistency than at any other point in your life. Even in a few days, the baby's stool will look very different. But the reason it looks so unique is because for however many months, they've been eating amniotic fluid. So the fetus actually swallows amniotic fluid, and floating around in the amniotic fluid is also cells from the amniotic sac that just slough off, like exfoliated. And so over time, they actually build up a little bit of this cellular waste in their intestines, so that they're actually practicing eating and drinking in utero all the time. And they don't poop in utero. They do pee, and they will urinate. Their little kidneys start working, and they actually pee out amniotic fluid and then drink it back up. It's not very pleasant to think about, but it's how they get practice and ready for living in the outside world. They don't release stool in utero, though, so it's the first stool once they come out. If they do release meconium in utero, that is problematic. That's a sign of fetal distress during labor. If a woman's water breaks and it's got meconium in it, that's alarming. The first breast milk that appears is very thick and often kind of yellowish in color. It's sometimes referred to as liquid gold. The medical term for it is colostrum, and it's very high in fat and very nutrient dense, very high in nutrients, because the neonate's, the newborn stomach, is very small. So you need a very nutrient dense source of food that is not going to, fill them up. That they can get a lot of nutrients in a very small amount of food, because they can only take in a small amount of food. So now for some diseases and conditions that affect pregnancy and childbirth. These are some for pregnancy. So oligohydramnios and polyhydramnios both have to do with amniotic fluid production. So oligo means scanty or few, and poly means many. So in oligohydramnios, this would be someone not producing enough amniotic fluid, and polyhydramnios is too much amniotic fluid. And this is something that the ultrasound technicians look for when they do ultrasounds. One of the things they measure is the volume of amniotic fluid, because, like I said, the fetus is actually drinking amniotic fluid and peeing it out. And so if they're not doing that properly, it can result in too much or too little. And that can indicate an issue with the placenta. It can indicate an issue with the fetus's kidneys, different things. So there is sort of like a normal amount of amniotic fluid, and if you stray from that normal, it can be a sign of other issues. Preeclampsia is a very serious condition that's fairly common and closely monitored. It's a condition of high blood pressure and protein in the urine, and it's a pre-indicator of a condition called eclampsia, which is seizures during pregnancy that can be fatal. And so if women develop preeclampsia, they're monitored very closely to make sure they don't develop eclampsia. So sometimes they're put on medications. Usually they're just told to relax, get a lot of rest, and monitor their blood pressure. And if it gets too high, they may actually induce labor, because the only thing that really cures preeclampsia is birth. Gestational diabetes. Diabetes is a disease where you don't process glucose properly. You can't absorb glucose into your cells. And there's many forms of diabetes. There's a genetic, there's an autoimmune form that often develops in childhood, where you don't produce insulin at all. And there's a form that is degenerative that you can develop over time, where you produce insulin, but your cells don't respond to it, so they don't take in glucose. But gestational diabetes is, again, just kind of mysterious. It's diabetes that develops during pregnancy and then goes away after pregnancy. So a lot of women who don't have diabetes develop it during pregnancy, and then it goes away right after pregnancy. So pregnancy hormones can basically elicit a lot of very strange changes in the body that we still don't really understand why or how, but that at least the good news is a lot of them go away after those hormones go away. So gestational diabetes is usually a temporary diabetes that develops during pregnancy. It does need to be managed because high blood glucose levels can be dangerous for both the mom and the baby, but at least the good news is it does go away. Hyperemesis gravidarum. Hyperemesis means excessive vomiting, and gravidarum, gravida, means pregnant. So this is like a really severe morning sickness. So not just like, oh, you feel nauseous or maybe you throw up once a day. This is like you can't keep anything down. You become severely dehydrated and need to be hospitalized. So some other diseases and conditions. Hydatiform mole or a molar pregnancy is a type of, it's really not a pregnancy. So what happens in a molar pregnancy is the egg and the sperm meet and fertilize, but then the cells don't divide properly. And so they divide, but they're not dividing and differentiating into different cells and becoming a fetus. They're basically just dividing and becoming a bigger and bigger and bigger ball of cells, just a mass of cells. But they do produce HCG, human chorionic gonadotropin, so they will result in a positive pregnancy test, and but not an actual pregnancy. So one of my good friends had a molar pregnancy. She missed her period, took a pregnancy test, and it was positive, and she was not expecting, like she wasn't trying, and so that she had a lot of complicated emotions because at first she was like, oh no, I had all these plans, but then she was really happy to be pregnant, and then she went for an ultrasound and they said there's no heartbeat, it's not a fetus, it's a molar pregnancy. So it was just a roller coaster of emotions of like, I'm pregnant, oh my gosh, I'm pregnant, oh yay, I'm pregnant, oh my gosh, I'm not pregnant. So sad. So to add insult to injury, since a molar pregnancy is really just cells dividing uncontrollably, that's kind of what cancer is. And so these cells, they have to be removed. So you have to go through a procedure called a dilation and curettage, where they dilate the cervix and then basically go in through the vagina and scrape all of those cells out. Because if they don't get all of the cells out, they could lead to uterine cancer. And in fact, so after she had that procedure, she was basically on a WAD. They did tests for a few months after that, they kept an eye and monitored to make sure she didn't develop cancer. So it wasn't just like, oh, guess what, you're having a miscarriage, which is already horrible news, but oh, and you also may get cancer from it. It was just awful. So this is a type of pregnancy that can occur, and is I don't know if it's, I mean, I think that is still considered a miscarriage because it was a fertilized egg that didn't form properly. So it is not an uncommon cause of miscarriage. An ectopic pregnancy is one that happens outside the normal location. The most common form of ectopic pregnancy is in the fallopian tubes. So it's called a tubal pregnancy. And so here we have, so what happens when the sperm fertilizes the egg, the sperm actually swim up through the vagina, through the cervix, through the intrauterine cavity, and they start swimming through the fallopian tube. So fertilization actually occurs in the fallopian tube, but then the fertilized egg is supposed to travel and implant in the uterus. But sometimes the fertilized egg stops where it is and it implants in the fallopian tube. Well, the fallopian tube is very small and it can't grow and support the growth of a fetus. So usually after a couple of weeks, as the embryo starts to develop, it puts a lot of stress on the fallopian tube and you experience severe pain. You go in, you get an ultrasound, and they find that there's a embryo in the fallopian tube. And sometimes it damages the tube so badly that they have to cut out the whole fallopian tube. So this happened to one of my aunts. Her first pregnancy, She, a few weeks in, had some serious pain, went in, and it was a tubal pregnancy, so they had to take out one of her fallopian tubes. So her and her husband were really bummed. My uncle was bummed, but they tried again and they got pregnant again. And lo and behold, she got a second tubal pregnancy. So they had to take out her other fallopian tube. And this was really heartbreaking because then she basically had a female vasectomy. She basically had her tubes tied at that point. She still had ovaries and she still had a uterus, but there was no way to get the egg to the uterus naturally in her body. And so this was in the early days of IVF, but my aunt and uncle had the means to try that, and so they did. They took eggs from her ovary and they took sperm from his testes, mixed them together, and implanted the embryo in her uterus, and she got pregnant, and she ended up having two babies with IVF. So all because of just being prone to ectopic pregnancy. But once upon a time, I'm going back, I always like to think sort of in historical context, especially when I like to watch shows like Call the Midwife, which took place in like the 50s and 60s. And if you think about it, how lucky she was to live in a time where she, A, could survive those ectopic pregnancies, where they could do surgery and remove them, because once upon a time, an ectopic pregnancy would kill a woman. They didn't have a surgery to remove the growing fetus, and the fetus would ultimately get big enough to rupture the fallopian tube, and you could have internal bleeding. Or there was time where there was surgery to remove the tubal pregnancy, but there was no way for the woman to get pregnant after that. And so then she was just, there was no option for her to have biological kids. But now we have a lot of technology that allows us to help people who have reproductive problems. All right, in labor, pregnancy, I guess we're still in pregnancy. So placenta previa is a particularly dangerous condition. So the placenta, ideally you want the placenta to be somewhere on the top or middle of the uterus. If the placenta is formed near the cervix, all right, and the cervix dilates and opens, the cervix is like kind of flexible, then that can cause tearing of the placenta that leads to massive hemorrhaging that threatens the life of the mother and the baby. So placenta previa is a really serious emergent medical problem. Postpartum hemorrhage is a bleeding issue. Even when the placenta is properly placed or located, when it falls away after labor, if it tears away from the uterus too violently, it can tear the uterus, or it can just bleed too much. And blood loss is a very dangerous sort of complication, very common and dangerous complication of pregnancy. Again, in modern medicine and hospitals, they can fix it relatively easily with a blood transfusion. But in like a home birth situation, the mother would have to be transferred to the hospital very quickly, because blood loss can happen very quickly and it's very dangerous. Premature labor is going into labor early. If premature labor starts with contractions, there's actually drugs that doctors can give a mother to stop contractions, and then the mom's usually put on bed rest, and so that the baby can keep incubating longer. But if the premature labor starts with the rupture of membranes, the water breaking, then there's no going back from that. You can't keep growing a baby in an empty amniotic sac. So it's the premature rupture of membranes, PROM, that is particularly concerning if somebody's not full term yet. We talked about the normal positioning of a baby for labor. You want them to be head down with vertex presentation. Right, so malpresentation is being not in that position, being in a bad position. So they could be breech, which is when they are butt down or foot down. A footling breech is one that has its little foot dangling out. They could be transverse, laying sideways. So if a woman, at 38 weeks or something goes in to her doctor for a check and the baby is breech or transverse, there is a procedure they can do to turn the baby, literally by massaging, not very pleasantly, the belly, and they can actually turn the baby around. It's called version, external version. And it does work sometimes. Sometimes it doesn't. Sometimes you can't get the baby to turn, or sometimes the baby turns and then turns back around again. So the reason it's more dangerous for the baby to come out this way is the baby's head is the largest part. So you want the head to come out first, not the body. And another thing in this picture that's showing not so great positioning is the cord here. So this is a prolapsed cord. The umbilical cord should not come out before the baby. So if the umbilical cord is poking out, the problem with this is the umbilical cord is literally the baby's bloodline. It's like its feeding tube. And in labor, if the baby is squishing that, if the cord is sticking out, and then when you're pushing the baby out, the cord gets pinched, okay, then the baby can't breathe. And the baby will be oxygen deprived. So you can't have the cord be pinched. I had a friend, this wasn't a prolapsed cord, but it was an issue with the cord in labor, and it's a great story. So she was in labor, and she was in the second stage of labor. She was pushing, and the baby's heart rate kept dropping, like a lot. And the doctors were really concerned, and they were like, that's it, we're going to do a C-section. So they went in, they cut her open, they pulled out the baby, and then the doctor just started laughing because she pulled out the baby, and the baby was literally, he was holding onto his umbilical cord. And so every time she pushed, he must have squeezed, and he was basically like strangling himself by squeezing the umbilical cord. So it wasn't prolapse, but it was an umbilical cord issue, and thank goodness for the C-section, because he probably wouldn't have survived a vaginal labor. Cephalopelvic disproportion is what's pictured in this image here. So cephalopelvic, cephalo head, pelvic, your pelvis, your hips, disproportion. So this is when the baby's head is larger than the mother's hips. Nowadays, this would be cause for a C-section, and it would be simply treated by removing the baby via C-section. But hundreds of years ago, that wasn't an option. And many women died, women and babies died in labor because the baby got stuck. They've actually found human remains, like skeletons, of a fetal head stuck in a maternal pelvis of a woman who died in childbirth. So again, thank goodness for modern medicine. So things like this are very treatable, or I don't know that you call C-section a treatment, but yes. Dystocia is a condition of painful labor, which makes me giggle when I define it, because all labor is painful. Most labor is painful. There's my husband. Say hi. But this is really talking about excessively painful. So sometimes a fetus will push on the tailbone and actually break a woman's tailbone on the way out. That's dystocia. A very common form of dystocia is when the fetal shoulder gets stuck. So the head is out, but the shoulder is stuck. Super painful. That's called shoulder dystocia. Like I mentioned, the first trimester is the most sort of sensitive trimester, and a lot of pregnancies don't make it past the first trimester. We call that, technically the term for that, a miscarriage in medical language is a spontaneous abortion, which is different than a therapeutic abortion or an elective abortion. So a spontaneous abortion is the medical term for a miscarriage. We usually think of abortion as a procedure that's done to remove a baby, and it can be done therapeutically for someone who the pregnancy is threatening their life. And it can be done electively in some states, where if a woman just doesn't want to have a child, she can elect to abort it. Dilation and curettage is a procedure that's often performed after an abortion or after a molar pregnancy to remove any fetal material, make sure that the uterus has been sort of completely emptied. It's a very unpleasant procedure. It's already an emotionally unpleasant time, but the procedure is called a D&C, commonly called a D&C. And then uterine inertia, I don't know why I have that on this slide. It'd be better on a labor slide. So uterine inertia is a physics word that the definition of inertia is, well, I don't know what the exact definition is, but something at rest stays at rest and something in motion stays in motion. So in uterine inertia, it's what we call when you have sort of a failure to progress in labor where your contractions stop. And this is not uncommon to happen after painkillers or like an epidural. So a lot of times women will get they're having really strong contractions, they get an epidural and then the contractions stop. And that's called uterine inertia. And if you can't get the uterus to start contracting again, in for the C-section. Some conditions affecting the fetus or the newborn, the neonate. Apnea, when the baby first comes out, if they're not breathing, we say they are apneic. Sometimes this happens and it's in the first few minutes of life, they haven't breathed yet. They were in utero, they were getting all their oxygen from the umbilical cord. Sometimes it takes a little rub down, takes a minute for them to get their first breath in. So apnea can be very temporary and not lead to any negative consequences. Respiratory distress syndrome used to be very common in preemies. It's improper development of the lungs. That's really the biggest danger with preemie babies, is that they have trouble breathing. Fetal distress is when the fetal heart rate drops. It's basically when there's something wrong with the fetus. So there's very limited monitoring that we can do. When a woman is in labor, you can't see the fetus. You can put a monitor on to monitor the heart rate, and you can see what you can see between the legs, and you can see anything that's coming out. So like if meconium came out, that's a sign of distress. If their heart rate is low, that's a sign of distress. So if there's anything wrong with any of those measurements, you can actually take that is distress. Jaundice is a yellowing of the skin. And in babies, this happens sometimes because fetuses have they make a different type of hemoglobin. And when they're born, they actually destroy all their red blood cells and make new ones to replace it with outside of the womb hemoglobin. And so if their livers aren't processing all those broken down red blood cells fast enough, then they get a buildup of bilirubin and it turns them yellow. Meconium aspiration happens if the fetus actually releases meconium during labor and then sucks, breathes when they come out. If they have a little bit of meconium on their face and then take their first breath and breathe it in, it can potentially get into their lungs. Most of the time, it's not a big deal. It gets suctioned out. The doctors and nurses will suction it out right away, and nothing more happens, but it is a potential risk for infection. Nuchal cord is the cord wrapped around the neck. If the fetus comes out and the cord is wrapped around the neck, which can be dangerous. APGAR score is a score that's given that the nursing and medical staff give to the baby in the first few minutes of life. So I think they get a 1-minute APGAR and a 5-minute APGAR. So when they first come out, and it has stuff to do with their coloring, their breathing, I don't even know, their heart rate probably. And so if a baby comes out apneic and blue, they may have a low 1-minute APGAR score, but then you give them a shake, do some aspirate, some suctioning maybe, and they breathe in, and then their color is good, and everything. By 5 minutes, they're looking great. They might have a good APGAR score at 5 minutes. So it's just a way to sort of score the health of the newborn. Some different laboratory and diagnostic procedures. Amniocentesis and chorionic villus sampling are becoming tests of the past. I don't actually know anyone. I don't think chorionic villus sampling exists anymore. Amniocentesis still does sometimes for certain conditions, for women who are maybe in their 40s and pregnant, but Now there's actually a lot of blood tests. A lot of diagnostic testing can be done with blood samples, but looking for things like some genetic markers for things like um, Down syndrome, cystic fibrosis, I think can all be, spina bifida can all be checked with blood tests now during pregnancy. And it's sometimes good to know those things beforehand because they may indicate issues for labor that the labor team should know, because it may be safer to do a C-section or to have a team of pediatricians ready when the baby's born if they have certain medical conditions. So it just helps the labor team prepare for whatever conditions the baby might have if you know about them ahead of time. There's also, of course, blood tests to test HCG. And there's the P-test that most people take at home, the home pregnancy tests, but doctors will want to confirm those with a blood pregnancy test. Ultrasounds, ultrasonography is for taking pictures, or I mean, you get pictures, but really it's for seeing internally. We can see lots of things internally, not just babies. Ultrasound techs look at all kinds of organs, but we mostly think of ultrasounds as looking at fetuses. And ultrasound technology has become so advanced, it's so amazing. This is an ultrasound picture. This is a 3D ultrasound picture. This is not taken with a camera, all right? This is a probe, like a little thing, like just a little wand stuck on, like, that's just on the surface of somebody's skin, emitting sound waves. And the sound waves bounce off things and come back into the detector. So it's like echolocation is how it works. It's just crazy to me that you can get that much detail from sound waves. Like, you probably couldn't see the baby that clearly if you opened the woman up surgically, because there'd be like, blood and guts and stuff in the way. But it's just crazy how clear of images we can get on ultrasound now. It used to be in the early days, just like TV static. And you couldn't make out a whole bunch, but now you can see quite a bit, and it's pretty amazing that you can do that using sound waves. An amniotomy is a procedure to make an incision in the amniotic sac. So sometimes if labor is not progressing, what can make it progress is literally rupturing the amniotic sac. So if somebody's water hasn't broken yet, the doctor can go in with a little tool and break the water, and it often speeds things up a bit. Can help labor go along. Version is what I was talking about when you massage the belly to turn a fetus that's not in the proper position, engaged position. Epidural anesthesia is the common form of anesthesia where analgesics are injected into the epidural space of the spine, and it basically numbs you from the waist down, and you don't feel the pain of labor. Induction of labor can be done if somebody is beyond their due date. The danger of going beyond 40 or especially beyond 42 weeks is that the fetus can just keep getting bigger and bigger. Also, the placenta can start to degrade and not work as well. And so late-term pregnancies like that are more a high risk for stillbirth. So if a woman is, also if a woman has small hips and the fetus is getting too big, so labor can be induced. And they usually do that by just giving you Pitocin, which is the same, it's basically oxytocin, which is the hormone that triggers labor naturally. Assisted reproductive technologies are procedures to help people who have fertility issues get pregnant, like my aunt. So IVF, in vitro fertilization, where in vitro means in a glass dish, where you fertilize an egg in a glass dish, and then you take that fertilized embryo, you let it grow a couple of days, and then you take that embryo and you put it in the mother's uterus, and it hopefully implants there and grows into a baby. There's another kind of sort of more intense form of IVF. So in, I guess, classic IVF, they just put sperm and egg in a dish and they do their thing. But sometimes the issue with fertility is the male. maybe the sperm are defective. Maybe they aren't able to penetrate the egg, or they have low motility or low sperm counts. So they can actually take a very tiny needle, suck up the sperm, and inject it into the egg. And that's what's being shown here. It's called ICSI for short, intracytoplasmic sperm injection, where they inject the sperm into the egg. And these have higher success rates. You get more fertilization. You get more embryos when you do it this way than if you just kind of mix the sperm and egg together and say, go to town. And so that's another way for couples struggling with fertility, especially if the male is having fertility issues, for them to actually be able to create embryos and conceive biological children. This is my picture of the Octomom, who a few years ago, she did IVF and gave birth to 8 babies. I don't think they would let that happen anymore these days. The success rates of IVF have gone up. They used to implant multiple embryos into a woman with the hopes that one would implant. And but sometimes they find that multiple embryos implanted, and sometimes those embryos would then split. And so even one embryo could turn into 2 or 3. And I don't remember how many embryos that they implant. I think she might have implanted 6, and they all stuck and 2 of them split. So she ended up with 8. But I would not recommend that for anyone. All right, some other procedures. Uterine suspension. So if labor is so damaging, like if you end up with uterine prolapse, then the procedure to fix that is a hysteropexy, to resuspend the uterus in place. A colporrhaphy is a procedure to suture the wall of the vagina if somebody has cystocele or rectocele or vesicovaginal fistula and they need the wall of the vagina repaired. An episiotomy is a procedure that is declining in popularity. So it's an incision made in the perineum in order to help the baby come out. So when the baby is crowning, if the head is kind of stuck, if the vaginal introitus is not stretching enough, then you can make a little incision, a little cut to widen that opening and allow the baby to come through. But a lot of research and it used to be thought that that was the best way, to make an incision rather than to let the woman tear. But research is actually starting to show that it's better for the woman to tear than to do an episiotomy, that episiotomies actually can lead to more complications. So, less common now. A cesarean section is a surgery to cut the abdomen and cut through the uterus and remove the baby that way. If the baby's not positioned properly, if the baby's in distress, there's so many reasons that C-sections can be life-saving. So we usually call it a C-section, but it stands for cesarean section. If you've had a C-section, it does make your subsequent labors a little bit more dangerous, because you now have a big scar in your uterus that could potentially rupture. And so after having a C-section, if you want to do a vaginal birth after C-section, there is a slight risk of your uterus actually rupturing at that seam. And so some hospitals don't support it. I know the hospital in Saranac Lake is working really hard to. The problem with it is they don't have enough anesthesiologists on hand because if the uterus did rupture, you would need emergent surgery, and they would need an anesthesiologist on hand, and they don't have a 24/7 anesthesiologist. So they, for safety's sake, don't necessarily support a VBAC. So if you have a C-section and then you have a second pregnancy and you want to have a vaginal birth, that is something you have to talk to your doctor about to see if it's a safe choice for you and to see if your hospital supports it. And that is the end of my lecture. Bye.